It is Schwartz Rounds Day, so.
What is it?
Schwartz Rounds.
Oh.
So, and the third years are, see ya. So it's,
That's true.
yeah. We talked about it's going to be a low crew.
I'm gonna put some residents one too. So that next time even you guys don't show up.
Do you want me to start?
Yes,
Start then.
please.
Okay. So for those of you guys who don't know me, I'm Jessica. I'm the current resident on developmental. So today we're going to talk about Tics and Tourette Syndrome. We're going to present with Dr. Bhatia and Dr. Lindsay, who both are our resident experts on this. So we have two cases, and the two cases are going to show the kind of the spectrum that we can see with Tourette syndrome. So this is our first kid. When he first presented, he was a 6-year-old male. First came in with repetitive movements. Parents said that it seemed to start when he was about 3 years old. The type and frequency of all these movements have changed. Mom says that the previous tics that we've seen too was that he initially used to bring his hands to his chest, and then the vocal tics, he would have this high-pitched exhalation sound, some growling. Currently, he's doing a lot of eye blinking, head nodding, neck popping, and mouth opening. I'm doing, in addition to the previous tics, also doing some throat clearing and coughing. So his past medical history, developmentally there were no concerns. He was developing normally, but he did have a really significant psych history. So he had really severe OCD that when he was in the office even, it was very obvious to the provider. He was really disturbed by lip movements when people were talking, got really agitated by people making this lip smacking noise, and he would just like shout, "Shut up," or call the provider an idiot. He was also very hyperactive. He got evaluated for ADHD, but didn't actually meet the criteria, but still had a lot of the hyperactive symptoms. And then did have really significant anxiety and depression. He endorsed suicidal ideation at some visits, complained about a lot of fatigue, worthlessness, irritability, poor concentration, and excessive crying. So really this is, you can just scan this really fast. The review of systems was really pertinent for what we had just talked about already. His general exam was all normal. His neuro exam was just some of the eye blinking and then the vocal tics that was observed. So for him, he's now 8 years old. He did get diagnosed with Tourette syndrome. He does seek counseling services, gets clouding at night with some improvement, and then he completed comprehensive behavioral interventions for tics. Symptoms-wise, he doesn't have any new tics, but he's still having pretty significant eye blinks, and like we had talked about, some of the other tics that he was going through. And he, in some of the notes, was saying that he felt like he couldn't stop these tics still. Okay, so our second case is a much more mild case of Tourette syndrome. He's a 17-year-old male who initially came in with a complaint of twitches, and initially started when he was 10 years old. Parents had first seen some eye blinking and lip curling, and now they just see that, some arm jerking and hand stretching and shuddering. And then vocal-wise, they heard some throat clearing, humming, and growling. So the difference for him is, developmentally he just has some stuttering, so he needed some speech therapy until he was 4. And then he, unlike the first one, doesn't really have much of a psych history, no OCD, ADHD, which are common comorbid conditions, and just some concerns with anxiety, but as far as I know, no actual diagnosis of anxiety. So for him, same thing, he had a pretty benign physical exam. Review of systems were, for what we talked about, the pertinent negatives, were the lack of OCD or ADHD. And then the neurologic exam, in the office we did not, or we saw just some stuttering, but none of the tics. So for him, like I said, also got the diagnosis of Tourette syndrome. He also got some therapy with behavioral psychology. He felt like he had significant improvement where he felt like he could, with his learned techniques, he could suppress his symptoms, or at least help suppress his symptoms. And medication-wise, he gets guanfacine, 1 milligram in the morning. Yep. We'll do that question. You want me to do a question now or later?
Just do it.
Okay. Okay. So I think you guys maybe got a copy of it.
Yeah, there's
somewhere.
handouts on the tables.
So we have an 11-year-old boy who presented with a persistent cough. It's been going on for 8 weeks. It's dry and harsh. It's worse immediately before bedtime. He hasn't had any fever, nasal drainage, headache, or vomiting. He's missed multiple days of school because of this cough. And they did a chest x-ray, which was normal. They tried a short-acting beta agonist, an antihistamine, antibiotic, and oral steroids. None of those worked. You're talking to the parents, and you feel like the kid seems really anxious. And the cough seems to be distractible. It lessens when he's playing games on his mobile phone. So on physical exam, he is a febrile, respiratory rate is 12. Nasal turbinates are normal, oropharynx is clear, lungs are clear, you don't hear any wheezing, stridor, or differential aeration. The heart sounds are normal, belly is normal, and extremities are warm and well perfused, no rash. So, of the following, the most likely cause for this boy's cough is A, bronchitis, B, foreign body aspiration, C, GERD, D, habitual cough, or E, sinusitis. You guys think?
Very difficult.
Yeah. D. Awesome.
Okay, we'll make it interesting though. Why do you guys think it's D? Just give me your reasons based on the history and exam.
It's distractible.
Okay, great. So that's one of the characters of. So habit cough is a kind of vocal tic. So it's distractible. What else?
No fevers or nasal drainage.
So that's like ruling out that it's not infection and chest clear, it's not bronchitis. But what else is characteristic of tic here? Like that, a positive sign, not a negative sign. Huh?
He's anxious.
He's anxious, so there's a sign of something comorbid there. And I think basically those are the big ones here, anxious and distractible. Yeah.
And
he got a significant
missed
workup.
school. Yeah.
What's that, Anna?
I was just saying he missed multiple days of school, but
Yeah,
all the
so
other
there's a
symptoms are
morbidity.
negative. Yeah.
So, yes, so that comes on to, and I'll talk about it, how intense the symptoms could be. I think she did try to highlight with her case that it's a spectrum, and that's the beauty of tics and Tourette's. So is that it
Yeah.
for you?
Jessica, just one thing on your first case, you
Uh-huh.
said that the first kiddo was on 1 milligram of Clonidine.
Uh-huh.
I think he was
0.1.
0.1.
Oh, thank you.
I have to be careful too. I'll skip the doses section.
It's the bottom one.
Oh, no. Okay, so I'll try to give you a brief overview of the clinical presentation of tics, just touch base on comorbidities and a little bit about the medications. And then Dr. Lindsay is going to talk about the behavioral aspect from presentation and then also from therapy standpoint. So just quickly, what is a movement disorder? Anything that involves, anything that has anything to do with voluntary or involuntary movement or posture is basically a movement disorder. And I want to highlight here, it may be accompanied by weakness or tone abnormality, but that does not characterize it to be a movement disorder. Big classification, either the movements are increased or excessive movements, or on the hypo side. We really don't see hypo that much in pediatrics, and really it's Parkinsonism, although there are pediatric varieties too, but extremely uncommon. So this is what we deal with, hypo. And the most common ones we see out of these are tics and stereotypies. Tics and stereotypies can really look alike, but because of the time, I'm not going to go into the details of other types, but I'm sure you guys have come across chorea, dystonia, apoptosis, myoclonus, and tremors. So again, focusing more on tic, what is a tic? A tic is sudden, It's a rapid movement. It's recurrent, but it's really not rhythmic, It's not that patient will do the same thing over and over again in a pattern, Unlike stereotypy. Stereotypy is the exact same movement. It sounds very rhythmic. It smells very rhythmic. Commonly, it's like the arm flaps or the hand flaps, It's in a rhythm, meaning it has a set frequency. That's not the case of this. And it could either be a movement or it could be a sound. And even the sound is the result of the action of muscle. So basically it involves muscle abnormality. Now common types of tics, they're basically classified as motor or vocal. And the motor is further simple or complex. Simple means one group of muscles. It's usually a lot focused around the head and neck area. So eye blinking, rolling of the eyes, lip smacking, opening of the mouth, neck jerking. These are the common ones, and then it could really involve other body parts as well. Complex means when it involves more than one group of muscles, and it sounds like a movement, like a purposeful movement, like gesturing. Yesterday I saw a boy whose body would stiffen and would smell his two fingers. So it seems like it's purposeful, but that's a tic because it involves multiple groups of muscles, his hands, his nose, he's sniffing, and then his body tenses. And the other common ones in complex are jumping, taking a step back. So complex ones really could involve any part of the body. Vocal ones, simple vocal again, just confined to one area, and it's basically a lot of nose and throat noises. So like coughing, throat clearing. Habit cough is a kind of vocal tic. Sniffing, barking. I remember seeing this tic when I was in middle school, and I was like, what's wrong with this girl? Now thinking back, it was a vocal tic. Our graphic designer is Anna. And I'll tell you why I'm doing this disclaimer. Complex vocal tics, so more than one group of muscles, so what it results in more formed vocal activity like words or expressions. Rare tics in the motor, copropraxia is, so copro means inappropriate, basically. So obscene or vulgar gestures. So the disclaimer, our graphic designer is Anna.
Hence the smiley face. I put the smiley face over it.
And echo is mirroring. So echopraxia. Echo is mirroring, praxia is movement. So mirroring the movement of somebody. So these are the rare motor kinds. Not that rare, but less compared to the other kinds. Like 1 in 20 of boys with Tourette's have this. And actually I come across this, and so does Katrina. And a little bit less percentage in females. Then the rare vocal ones, or relatively rare, are coprolalia is, I see this all the time, and you can see it's in 1 in 5 with Tourette's. So spontaneous, non-intentional utterances, it could be a profanity or a religious slur. And yesterday I had an 8-year-old, the same boy, who would sniff. A mom says, he just says the party word, and he just can't stop himself. And he has to just say it, and he regrets afterwards. So that's classic for coprolalia. Then echo is again, what somebody else does, so repeating the last heard sound word. So this one says, are you going? And then this one says, are you going? And palilalia is repeating your own words over and over again. It's usually in a decrescendo time. So, the volume intensity goes down. DSM-5 criteria, so talking about some definitions. What's a Tourette syndrome or Tourette's disorder? When you have multiple motor and at least one vocal tic, they have lasted for at least a year, and they don't have to be present every single day of the year. Earlier criteria said that there should not be a tic-free phase of 3 months, but that's gone. So there could be a longer gap, and diagnosis has to be before 18 years, and you don't have an obvious secondary cause like a drug or other medical condition. Other big definition is persistent or chronic motor or vocal tic disorder, or CMVTD. You have either motor or vocal, but not both, and rest is similar to Tourette's. So lasted for a year, diagnosis before 18 years, and you specify here whether it's motor or it's vocal. And then the third definition is provisional tic when it doesn't fit into the first two. So you can have both motor and vocal, but here what's important is the duration, less than 1 year, and everything else is same. And here you don't need to specify motor or vocal. So prevalence, you can see 1 in 5 of school-age children at some point of time, but most of them it's transient or like lasts less than a year. Prevalence of Tourette syndrome is 1 in 166, and of both chronic motor and Tourette's combined, meaning those that last at least for a year, is 1 in 100. So 1% of the school-age kids, we see them, and yes, it's very common. Age at presentation, motor tics usually present early. I have seen them as early as 3. You know, you always have to think of other differentials like seizures, especially at this age. But tics really speak for themselves. So I didn't even think of putting a slide here for differential. The vocal ones are present a little later, usually when it's the early to mid-school. And this is the eye tic, eye blink. So characteristics of tics, what defines a tic? They fluctuate, meaning they vary throughout the day, weeks, months, periods of illness. You'll have more tics just spontaneously. There are better days and worse days. A child can temporarily, voluntarily suppress it, but you know, when you ask them, it makes them uncomfortable. It's distractible. So if you make them engage in some activity, something different from what they're doing, you know, the tics can be, and I think our kid was distractible. The cough was distractible. They almost always disappear during sleep. Basically, all the movement disorders do not occur during sleep. The rare exception is palatal myoclonus, but other than that, everything else is gone in sleep. They worsen with stress or anxiety or excitement. Premonitory urge is like the itch before the sneeze. You gotta sneeze. So when you ask the tickers, and especially this thing comes more so around 7 or 8 years of age, then how do you feel? Like, you know, if I tell you not to tick, like what exactly are you feeling? And they will describe it to you often like, you know, I have that itch, I have the urge, I have to tick. Suggestible, so this often happens when we see the patient with the family in that enclosed room. They tend to tick a lot because, you know, we are talking about their tics. They may or may not have an obsessive compulsive component, meaning like they need to perform the tic in a particular way a particular number of times until it feels right. So they may have comorbid OCD, or they may just have an obsessive compulsive component to the tic. Comorbid conditions, I cannot speak enough, you know, about that, and that's why we cannot speak enough about Dr. Lindsay, because like nearly 90% of the kids with Tourette's have comorbid conditions. The common ones are ADHD, OCD, ODD. They can have all kind of behavioral and mood issues like anxiety, depression. You can see this big circle out here. Learning difficulties, behavioral issues, all kind of sensitivities, texture, food, smell, you know, anything you think of, sleep disturbances, executive function, fine motor skills. So there's a never-ending list, but the common ones are ADHD, OCD, anxiety, if I have to pick 3. So here this shows the lifetime prevalence of any comorbidity. Psychiatric comorbidity is close to 90%. Either OCD or ADHD criteria is met in about 2/3 of the patients. And in more than half, you will see 2 or more comorbid conditions. And the mood disorders is about seen in a 1/3. Now, why do tics happen? We simply do not know. Despite multiple studies, animal models, the theory is, and you know, which is being proven to be more and more right, that it has got something to do with the abnormal brain circuitry. And this pathway is important to remember, the corticostriatothalamic pathway. Basically, this is to blame in all movement disorders. And I'll show you the picture in a second. It's the cortex with the basal ganglia and the thalamus. The common neurotransmitters, many neurotransmitters have been proposed, but dopamine and serotonin are the common ones. We do believe there's a genetic component because tics tend to run in the family members. Monozygotic twins have, you know, a higher incidence. There is definitely a developmental role as well, because the early school age, like I said, 1 in 5 kids will have tics at some point of time, but typically over time as the brain develops and matures, for all tic kinds, they tend to improve. And they could be secondary drug-induced, like stimulants used for ADHD. So this is the pathway I was talking about, cortex, basal ganglia, and thalamus. There's a direct and indirect pathway, which in general controls all kinds of movements. Direct is excitatory and indirect is it inhibits. So Tourette syndrome, like I was just mentioning, the long-term course Typically, tics tend to improve by late adolescence in 2/3. 1/3 remit, 1/3 improve, and 1/3 remain the same. Very important to note here, comorbidities may not improve with age, and if a child has comorbidities in general, they tend to have worse prognosis compared to those who do not. Treatment goals. So, it seems simple on the face, Tourette's, but really treatment requires the cooperation of the family members and, multiple specialists. First, you have to evaluate the tics, how severe the tics are and how disabling they are. And I know Dr. Lindsay does use the objective Yale Global Tic Severity Scale. You have to evaluate for the comorbidities because remember I said they really affect the treatment. Then you have to individualize treatment based on how morbid is it for the patient. Must to treat the comorbid conditions. We may or may not directly treat the tics. So know your goals, be realistic. There is no cure for tics, okay? They wax and wane, so they may just decide to be better, and in general they get better with time. Our aim at that time is to improve the functioning level of the child. Very important point, for parents, home should be a free ticking zone, a safe ticking zone. A lot of times it's the parental anxiety that's worsening and bringing up tics in the kids. When do we attempt to treat? When it's something that's causing physical discomfort or pain, especially the neck tics. I have at least 2 or 3, I have the pure reason to start them on treatment is, the neck jerking, it's dangerous. They can, first of all, it's painful, and then, they can hurt themselves badly. If it affects their socialization, their self-esteem, middle school, very common, kids are picking on them, and you got to treat them at that time. Or if the child is really asking to do something about my tics, but this is not the indication, that's why I put in star. Parents cannot tolerate tics. Treatment, it really starts with psychoeducation, You should spend, I would say, at least half of the counseling session on just the counseling about why tics happen, what's the natural history, so give them a hope. 2/3 get better, but be realistic, talk about comorbidities. Talk about triggers, a lot of time the situational, they can make things better. And then next, behavioral therapy. It's relatively recent compared to medications. It first came out in 2000. People really have not been using it that much except for past few years. You need trained therapists to do it, and we are very blessed to have Dr. Lindsay, and very few centers have trained therapists. But they really have great results. We are actually doing summer project comparing the medications with the behavioral therapy. And I know anecdotally we have great results. Next, medication. So I'll briefly talk about medications and I'll leave the behavioral aspect to her. These are the common group of medicines. Alpha-2 adrenergic agonists, antipsychotics, us being neurologists, anti-seizure medicines creep everywhere. So Topamax, it works. We don't know the exact mechanism. And then the other, those help with muscles like tetrabenazine, baclofen. Now remember I told you the top 2 neurotransmitters proposed have been dopamine and serotonin. Alpha-2 agonist has nothing to do with it, okay? So we exactly don't know how it works, but we believe it's, in general, these are antihypertensive medications and they decrease the sympathetic outflow from the brain. And that's what we think is the mechanism for both ADHD as well as for tics. And they are actually non-labeled. So the only FDA-approved drugs are antipsychotics at this time. But because of the better side effect profile, we use them as first line. Clonidine and guanfacine. Common side effects could cause some dizziness, they can drop the blood pressure, but really, in younger kids, I have never come across hypotension as a problem. And sedation, and that too more with clonidine. So in general, very well tolerated. So I think I have the dose correct. It's the point, so this is an important point actually. Epic cannot let you go wrong, but in general, when you compare clonidine and guanfacine, it's 10 times. The guanfacine tablets are 1 milligram, and the dosing is 10 times clonidine. I'm not going to go into the details of dosing, but when should you consider using clonidine and this associated ADHD? Because it does help with both. And when will I choose clonidine over guanfacine? So same both with associated ADHD, but clonidine is more sedating, so consider it more when a child has sleep issues. Topamax, actually 2 years ago we also did a brief summer project at our place, and I'll show you the slide in the end. And it was just on the treatment outcomes of Tourette's. We didn't have that many patients with therapy at that time. But the top used drugs at our place were clonidine, guanfacine, and Topamax. So Topamax does have, it was like the third number drug. Side effects wise, it can cause paresthesias, it increases the risk of kidney stones, so a lot of water. Some people can have trouble concentrating, trouble thinking. Not a significant cause in stopping medicine, but in a small percentage it could be, and a rare side effect, it can cause glaucoma. Now, antipsychotics, so typical or class 1 and atypical class 2. The 3 FDA approved ones are haloperidol, themazide, and I think it's aripiprazole. Not risperidol. But these are the 4 which are used, if we think of antipsychotics. In general, we tend to prefer using the second generation over first generation because of the better extrapyramidal profile. But you have to monitor with, and I just picked 1 or 2, and they really work well. The efficacy standpoint, antipsychotics work better than the alpha-2 adrenergic agonists, but again, you have to worry about the side effects. So I just picked orapimazide. It's dopamine antagonist, and side effects wise, it could cause weight gain, it can cause extrapyramidal movements themselves. You also need to monitor for arrhythmias because they can cause QTC prolongation. So always obtain EKG at baseline and then 3, 6, and 12 months. When do you use severe tics? And if there are other behavioral issues, when you in general are thinking of starting antipsychotics, it's a great choice. And then second line, risperidol is both dopamine and serotonin antagonists. Side effect profile, I think it causes more metabolic syndrome, but less extrapyramidal. And again, use when you have severe tics or aggressive behaviors. You need to monitor with the labs, the metabolic labs, and also the EKG. Another important point I want to highlight to you guys, especially when you work in the ER, sometimes tic patients present to ED with just acute exacerbation. And at that time, doing benzos for a week or 2 is a great idea. Because if you start clonidine at that time, it's not going to work that well. And this has worked on, I think I have come across 3 or 4. In the past 3 or 4 years, it has worked on every single patient. So clonazepam, it's a good thing for you guys. Maybe you can save a phone call to neurologist. Just bring home on clonazepam and tell them to call the office next day. So to see a mean motive. To summarize, treatment of Tourette's is a partnership with the family, physicians, therapists. And the tics is a roller coaster. Just remember, they fluctuate, there are better days, there are worse days, but in general, they tend to get better with time. So this is a poster from the project that we did 2 years ago, and what I want to highlight is, in the vocal tics, the most common one, the yellow ones are the throat noises. The motor ones, it's facial, like I said. The drugs, the 3 most common ones are clonidine, guanfacine, and Topamax. One more point I forgot to highlight with drugs. At best, data shows that they result in 20 to 50% improvement on symptoms. So, which is unlike behavioral therapy, as she's going to talk to you. Behavioral therapy, we had at that time, out of 50, we had only 7 patients actually get behavioral therapy. Most of them went outside, and they had 100% improvement, unlike those on meds had about 50, 60% improvement. And that's it. So I've set a stage for Dr. Lindsay. Now she's going to come.
All right, Dr. Bhatia set me up. I'm feeling all kinds of confident here. Good old Steven. So we'll go pretty fast. First, I want to introduce you to this little guy right here. That's actually the symbol of the Tourette Association of America. And both Dr. Bhatia and I feel like when you have a family that's just starting to begin this tic adventure, probably the #1 resource you can give that family is this website. And then also I picked teal because that's the national color for Tourette. So we went over this. Kind of the goals for you is just to understand how do we talk about tics and how do we treat tics from a developmental and a behavioral perspective. You can see here that the biggest change from the DSM-5 and for a lot of diagnoses is that we took out functional impairment, right? So a lot of times tics, we think tics and associated stress would make a tic disorder. Now we don't have to have that associated stress. For a lot of the patients that I see, they do have associated stress, and then that's how they end up here at CVIT. I say this a lot to families because when families think tic, most of the time they think Tourette. And Tourette is not a diagnosis of intensity, it's purely symptom count. And so families are often relieved to hear this when I give a Tourette diagnosis. You know, when they hear Tourette, it's like back in the day when we used to think about autism and Asperger's. You know, the tic disorder might be like Tourette light and Tourette's really heavy. And so what I say is that I've seen a lot of kids profoundly impaired that really only make criteria for motor tic disorder, and then I have kids that don't have as much impairment but make criteria for Tourette because they made those minimal multiple motor and one vocal or phonic. So Dr. Bhatia went over this, but pretty much the bottom line is that tics are really common. One of the pieces that I always go over with kids is I talk about the concept of chronic. What's a chronic condition? And how is chronic different from acute? Because I want families to know that this might be something that follows kids along for their lifetime. The best analogy I have for a chronic illness that I give to kids, whether it is Tourette or asthma or diabetes, is it's like you're on your school bus of life, you know, and you're the driver. And this bus is different because this bus has no doors. So what you have on your bus is what you're going to take on the highways and the country roads. And sometimes tics are going to be in the back of the bus, totally silent. And other times tics are going to be in the front of the bus, telling you when to turn left and when to turn right. And so every child, you know, whether we think they're going to grow out of this or not, we have a really upfront and honest conversation about what a chronic illness means. So Dr. Bhatia did a very nice job talking about this, and I can actually jump onto what you said about that first patient we presented. I would say of all the kids I treated, I can count on one hand the kids that I saw that only had tics. Most of the time, you have a little bit of flavor of anxiety or a little bit of flavor of OCD or a little bit of ADHD, and sometimes not enough to meet criteria, but enough to see it in the room. So when I think of that first patient that you presented on, his OCD was worse than his tics. And right now I actually see him today to work on OCD. Because what would happen is that if I engaged in lip smacking or said one of his hot words, it would cause him to just go into a tic explosion. And he's actually one of the few rare kids that I've seen that has coprolalia. And that coprolalia would be triggered by me saying words like mother or father or licking my lips. So that's a pretty traumatic and intense experience for kids. So Dr. Bhatia also did a really nice job of talking, how do we walk along this line? What do the differential look like? How are we making that jump between OCD or complex tics, or ADHD hyperactivity versus tics? And so I really lean heavy on the Yale Global Tic Severity Scale. So if you guys want a copy of that or want to take a look at that, it's a really great measure because it helps you kind of flesh out what are tics and what might be related to these other diagnoses that are highly comorbid. So if we have, you know what, I'm going to make you guys do it. Let's all have a tic, shall we? So what I want to do is I want everyone to hold their eyes open for 1 minute, okay? So don't blink for 1 minute. It's like the old staring contest you used to do when you were kids. So maybe take this second right now, get those blinks out. I'm watching the clock. Ready?
It's better than the no bitch.
Ready, go.
I'm not even trying.
I see a lot of bloodshot eyes, so maybe I'll let you off the hook a little bit earlier than an entire minute. Okay. In 5 seconds, I'm going to tell you you can blink. All right, ready? Go ahead and blink. Okay, so that experience that you had when we were getting up to that 10 seconds or hey, at the end of the minute, you know, that build of I just gotta do this, I just gotta blink, my eyes are on fire, and then the accompanying relief is the best example that we have for kids that experience tics, right? So that urge, I just gotta do it, my eyes are screaming, I really need to do this, and then being able to blink and that, that's what tics feel like frequently throughout the day. And so when we think about kids that experience tics, Dr. Bhatia is right that it's a roller coaster, right? We are riding all day that feeling of, I just gotta do it, having the tic, and then the relief. But then what happens next? What happens next after we have the relief? That relief might last for a couple seconds, might last for a couple minutes. For some of our lucky kids, it might last for an hour, but then we start the roller coaster again. And that really points to the functional impairment that's related to this diagnosis, even though it got kicked out of the DSM. If I'm riding this roller coaster every day, how am I going to do on my SATs? How am I going to do when I'm trying to concentrate at school, when all I'm doing is riding the roller coaster of urge, tic, relief, urge, tic, relief? And so the way CBIT works is we spend the majority of those initial sessions getting really good at the red. So what are our body's signals that tell us we have to tic? And if kids don't have an urge, I start thinking about a lot of those other diagnoses that Dr. Bhatia went over, right? There's been 2 kids since I started CBIT that we went over the premonitory urge and they're like, I don't have it. I do not have this. And one kid actually had an internal medical condition, so we actually ended up sending him over to the ER, and the other one had a conversion disorder. So I've realized just how important it is to rely on the kid's definition of urge. And it's funny because parents will say, oh, they don't know when it's going to happen. If you spend time with that kid, yes, they do. Yes, they do. Their language might not be able to give you a really accurate description, but every kid, whether they have a diagnosis of an SLD or ADHD, can tell me what that feeling feels like before they have a tic. So this is how the behavioral model approaches tics, is we spend a lot of time on what are those antecedent conditions? Where are those places that tics happen most? And is it a place or a situation, like at school? Is it around specific people, like a judgmental parent? Is it during activities? Is it internal experiences? I had a young guy who had tics everywhere. We couldn't figure out what that antecedent was. Like, was it stress? Was it excitement? And it came down to him telling us, oh man, I had this really bad baseball season. I was the youngest player on the team. I was teased like crazy, and every single time I thought about baseball, that's when my tic came out, right? So think about those internal experiences if you're not able to define a specific antecedent. So for lots of kids, that experience is school. And that's the reason why here at Akron Children's, we do CBIT and not habit reversal, because there's a significant difference between those two. When I hear habit reversal, it's like my DDP's family that hear ADD, where it's just like, oh, I want to correct it, but Habit reversal is specifically tic related. CBIT, that C stands for comprehensive, which means if tics are having me have massive issues with focus in school, I as the provider are going to spend as much time on school as I am about tics, right? Or if I have a parent that just doesn't get it and doesn't understand and thinks this kid's faking it, we spend as much time on that. Or if I have a kid that's so anxious they can't even sit for an exam, much less control their tics, we pay attention to that. That C is really important. So then, finally, after we figure out those antecedents, we have to figure out what's going on in the environment that's allowing tics to keep happening, right? Sometimes that can be positive reinforcement. I have this happen a lot at schools. So schools will say, oh, we are so aware of Tammy's tics, and you're going to be so proud of us, Dr. Lindsay, we're doing the right thing. Every time we see her tic, we let her go to our stimulation room and just, tic it out and play and, roll around on the phone, and then she can come back after she's done with ticking. What's the problem with that? Yes, it's getting reinforced, right? So I spend a lot of times talking to schools like, that is awesome, I am so happy you are partnering with us here. But what we want to do is when Tammy feels the urge to tic, that's when we reinforce her with that. Not when she's ticking already, because these kids aren't consciously doing it, but that makes an association in the brain of, oh, if I do this, I get to escape math class, which is already pretty stress-inducing to me. So again, old school habit reversal. Habit reversal has been around since the early 70s, and it came out of the really foundational research of Azrin and Nunn. So Azrin and Nunn actually went into psychiatric facilities and retirement communities and established something called a token economy. So this was one of the foundational studies that all of us with psychology backgrounds probably remember, right? And that is focusing specifically on awareness training, selecting a competing response, giving some social support, and relapse prevention. So I would say of the 6 sessions that I see kids receive it, we probably spend 2 to 3 specifically on habit reversal, but the other 3 on that big C word, which for us is comprehensive. What CBIT does is CBIT adds patient and family education. We take a whole session, I call it my science session, and my patients at the end know what the basal ganglia is. They can say that word. They know what a competing response is. We actually look at the map of the brain and look at the frontal lobe and look at where the basal ganglia is together. And a lot of times after that session, that's my second session, we have a huge dropout in tics because there's something so powerful about putting the kid in the driver's seat with this diagnosis, right? So this extends HRT by doing patient education, working on that functional intervention, so that's that antecedent and the consequence, doing a lot of school outreach. I'll be on the phone a lot with schools talking about, will this kid qualify for Section 504? Do they need a health plan? Does their school even know that they have tics? You know, doing teacher education as well, that we can't punish kids when they're having tics, or kick them out of the class if their habit cough is a little bit annoying to others. And then we take a whole session and work on stress management, because what Dr. Bhatia said, we know these kids a lot of times are stress cases, so we'll take an entire session, dim the lights, and put together a relaxation menu. And then that menu follows them for the rest of the sessions, because all of us in this room don't know how to relax. That's why we're in this field. So, you really allude to this, Dr. Bhatia, but I have referrals coming from the most unique places, right? So obviously my number 1 is neurology, but then I do have referrals coming from the allergist and the pulmonologist. So why would that be? Thinking about some of those cases we talked about in that quiz question that you had. Why would an allergist refer someone to me?
Cough, itchy nose.
That's right, right? So these kids, a lot of times by the time they see me, have spent years with a mystery cough. And they went to go see the allergy doc, and they went to go see the pulmonologist, and no one could figure out what it is. And then finally, someone smart like the people in this room said, well, you know, maybe this is not a this is a habit cough, right? So I get referrals from very interesting people out there. Again, you can see the ADHD clinic because of those comorbidities, outside therapists that maybe don't have training in CBIT. So CBIT is an intake plus 6 weekly sessions. So it is very intense, and then we're done, right? 6 weeks, that's fast. Every single week at the exact same time. So for my intake, I do the YGTSS, which is an awesome measure, and then we jump right in. And so this is my little brochure here. We just had this brochure developed, and when they first developed it, they had a bunch of sad kids on it. Like the saddest faces you've ever, just like, you know, and I went back to PR and said, I can't do this. I need happy kids. And lots of boys, because I have lots of boys in my clinic, but because this is a fun treatment. We are really open with tics. I feel bad for my neighbors that are in this room because we're loud. You know, we will call the tick forward to talk about what those antecedents are. You know, it's a very dynamic, active therapy, which is fun. It kind of matches me, you know, because I'm relaxed. So that very first session, like I said, we jump right into the science. So we know the basal ganglia. I like to tell kids that basal ganglia sounds like something you put on your salad or a British rock band, right? We talk about the history of tick treatment, right? Back in the Victorian times when these ticks showed up, they would go to the doctor and the doctor would say, just stop doing that, hold it in. And ADHD boys love this, but I say, you know, holding in a tick is like holding in a fart. Right? It takes up your entire body. You are like trying to concentrate talking to your colleague. You are like pinching everything, right? And then the second you're alone, what do? You just let it rip, right? That's like holding in tics, right? So I have lots of kids that maybe session 2 or 3 will come see me and say like, oh, I'm doing awesome. And I can see like maybe their eye socket's blown, you know, like, and I'm like, what's going on? You know, they're like, I don't tick all day. But then their parents say, oh my God, they come home and just explode, right? The difference between holding it in and CBIT is we're trying to teach a competing response, which is when you start feeling that urge to tick, what is something that we can do that will make the tick impossible to happen, but it's a physical action, right? So if I have a kid that comes in with a tick like this, we spend a lot of time talking about what that urge feels like. And that's why I actually have a full-length mirror in my office. We will look at the tick and just think about where it's starting, right? And then I don't give it to them. We come up with something we can do instead of that. So if I have a tick like this, probably one of the easiest things I can do is tuck my elbow into my hip, right? So when I feel that sensation coming, I tuck my elbow into my hip. My rule, I call the Dr. Lindsay rule, is that I want you to be able to stand at a bus stop and nobody knows what you're doing, right? I have a lot of really funny, creative kids that'll be like, oh, so I don't do this, I'm just gonna do this, right? And then I say, can you play baseball like that? Like, what would happen if you were in class all day like this? What would people think, right? We're trying to think of a physical movement that no one else even knows what you're doing. And I don't force them, they have to come up with it themselves. All of my kids, again, because most of them have ADHD, we are also on a behavior plan. So I partnered with volunteer services, and if they can stay focused and participate and finish their homework, they get a prize at the end, right? And we spend a lot of time talking about the brain and brain electricity. That basal ganglia, we're going through the motor automatic cortex, and when we start talking about antecedents and consequences, we start going in through the frontal lobe. And so that's brain electricity. We're rewiring the brain. And I get a lot of buy-in with that, because then they think we're doing science, which is awesome. So that second session, that's where the rubber hits the road. That's when we take the first tic, not the first tic that's most annoying to mom and dad, but the first tic the child wants to work on, and we start nipping it. So we do something called awareness training. So that's mom and dad, we come up with a code word, so maybe the code word's Bob. So then for a whole week, if they see their child doing their tic, we say Bob, right? And that is for them to say what's going on around me and what's going on inside, right? Then we do something called fake talking. That's what they do with me in session 2. So we'll have an entire conversation, and I want them to do their tic, and I catch them. And then I mimic their tic back, and they catch me, right? That's adding frontal awareness to something that's been automatic, right? We develop our competing response. We practice, and the rule of thumb is always we want to hold that competing response for a minute or until the feeling goes away. A lot of my kids with ADHD and anxiety don't know what a minute feels like. So we will literally watch the clock for a minute so we know how long that is. And sometimes we're holding that competing response for 8-10 minutes. But that's our brain trying to knock on the door and we don't answer, right? And so for a lot of my younger kids, we'll do this right in session. I had a young lady, she was 6, and did amazing in this treatment. But it took us pushing pause and having her hold a competing response for like 20 minutes while we all watched. And then after she realized she could do it, the rest of the thing was cake. Like Dr. Bhatia said, I have a little massage person here because I've also partnered with the pain center because so many of the kids that I see have chronic pain associated with their tic, right? If I'm doing this all day, my neck and head are going to kill me. A lot of my kids that have squinty or eye blink tics, they always complain of those frontal headaches, right? So the massage team will come and either see my patient a half hour before or half an hour after, and they're doing very targeted massaging where those tics live. And that's been a really beneficial service that we probably started in the last 2 months. So 3 and 4, we keep going through all of those tics. A lot of times I do eye tics in 3 and 4 because those are notoriously the most difficult tics to get rid of. Right, that session 5, that's when we push pause on everything, and we talk about relaxation and belly breathing and guided imagery. My neighbors here can say, they know when it's a relaxation day because all the lights are dim, we have the sound machine on, I have like a little trippy light thing that goes around, we really make it relax and have a serious conversation about that. We make a menu, this is one of my patient's menus he made, so he's given homework that he has to relax 10 to 15 minutes every single day until he sees me. So we'll write this together, and then those are the things that he can do and he found relaxing. Session 6, that's where we spot check, make sure you have all the skills. We talk about relapse prevention. I always like to give the example of Muhammad Ali. What made Muhammad Ali the best boxer? Not he was the biggest, not he was the strongest or fastest, but because he could predict the punches coming, right? And we talk about when you're done with the treatment, what are the punches in your life that might make your tics go up? Because this is a chronic condition, right? I pull a lot of examples in my previous experience with healthy weight, because healthy weight's a really concrete example of what relapse could look like. You're exercising, you're doing great, you're eating healthy, and one thing happens, you start gaining weight again. What could that be? The holidays, a sports injury, that kind of stuff. That's related to tics too, right? I see awesome kids that don't have tics, and then suddenly they're about to ask a girl to prom, and their tics come back, right? That could be a situation. They're excited and stressed. So we talk about what could be the things that could happen to make my tics come back. And then we have a big fancy graduation ceremony where I let them wear my lab coat, and we do a diploma, and they get their behavior prize, you know, and play with pomp and circumstance, and then we're done. So here's just a picture of some of my amazing and awesome graduates. I don't know if I'm violating HIPAA by putting this up, but. And then here's some awesome resources. There's great books. Like I said, the Tourette Association of America is amazing. And there's a lot of really neat camps. So this is actually a national camp, Camp Twitch and Shout. And then I have a local camp, some resources in my office. Just a warning that if you know, for some miracle, never see a kid with tics again, one of the most important things you can do is to be an advocate, right? So here is just a brief search of, you know, funny memes that are related to Tourette's. A lot of people love saying, oh, I swear I have Tourette's, oh, it's my Tourette's acting up. You know, that's a really hurtful thing to say if a kid's going through that, right? And we know that coprolalia is pretty rare. So this is your opportunity to give patient and coworker education. Okay, so June 7th was World Tourette Awareness Day. And
the month.
Yeah, that's right. It's the whole month, that's right.
And I think May 15th
To
to
June
June 15th.
That's right, today.
This month.
Yes. And then I am working with the NDSC. We are going to have the first ever TIC night out. So TIC stands for Together in Community. So we are going to Sky Zone in Canton August 6th. So you'll be hearing about that because I need some volunteers to come help me jump with these kids. And then finally, right here at the end, it was one of our awesome cuties that went to Washington, D.C. He was the, we're laughing because we know him very well. He was chosen as the Ohio representative for the Tourette Association. So I love this picture because you can see everyone's kind of nice and suited up. And then here's our boy right here repping that plaid, you know, being quite the Midwestern kid. So this was a huge thing for him, but he's now like a Tourette representative and goes and talks to schools and gives peer education. So there's good things happening here at this hospital. Awesome. So in the last couple of minutes, I went fast. But do you have any questions with what behavioral intervention looks like for TIC and Tourette?
I have a quick question.
Mm-hmm.
In the cases that Dr. Lynn had presented, you know, how do you have that ADHD rule out? You know, so what was it that, okay, they definitely don't have ADHD. So what kinds of things are you doing to rule that out and sticking with the Tics Tourette track?
That's a really good question. So for that patient, he actually went over to the ADHD assessment clinic and did a full-blown ADHD academic achievement and IQ assessment. And so from that, Dr. Putt felt like he did not meet criteria.
Okay.
You know, I will say that oftentimes ADHD is my biggest battle when we're talking about TIC treatment, because TIC treatment, you have to have focus, and you have to have motivation, and you have to be able to participate. And so that's where that behavior plan and that reward system, although kind of goofy, has really helped me out. You know, because I use that as an opportunity to model for parents how, you know, positive reinforcement works. So that's a really good question. You know, a lot of times I will talk to Dr. Bhatia and we decide what are we going to treat first, right? So if anxiety is so bad that CBIT isn't going to work, they have to go get their anxiety under control. And then once I get the green light from that provider, then they can come back and see me. And we've had that conversation before. So I've had a couple patients that we've gone through the intake. I've done the big Gale Global Tic Severity Scale, and I'll be up front with the family and say, you know what? I don't think you're ready yet. I don't think you're ready. And actually that happened with that very first case that was pretty complex. He came to see me. He was so out of control and inappropriate that I said, you know, we need to really think about if you're 100% behind this. You know, the analogy I like to give is that CBIT is the gas station, right? You come to me to get your fuel filled, right? But you have to take the car out and drive. You have to take the car out. I'm only teaching you the skills in this tiny little blue room. It's up to you to take it out of here, right? And he wasn't ready yet. And so that was tough with Mom, but I knew when he came back to me a couple months later, we were really ready to work. Good question. Any other questions? Great, awesome, thank you guys.
Then I have the code for the resident.